Good afternoon. I'd like to acknowledge and thank the Prostate Cancer Foundation and Graham and Mark in particular for doing an exemplary job over the last 5 years or so. I remember when I returned from the US about 12, 13 years ago, we didn't really have such an active Prostate Cancer Foundation, which is the advocacy group for prostate cancer. And we still today don't have any such thing for bladder cancer, which is my other area of interest. And Sue Osborne, my colleague at North Shore, and I frequently bemoan this and look around to see whether we can get the poster boys and the interested people looking after our other area of interest, bladder cancer, among the patient and relative population. I'd also like to acknowledge Sue Osborne, my colleague for many years, one of the best nurses I've known and such a professional and caring person. And I was very pleased to encourage her to join the board of Prostate Cancer Foundation. And I'm pleased to hear from Graham that she's contributing well. Thanks for that. So I'll get on to my talk. Today I thought I'll talk to you about where the future for prostate cancer surgery is, and in general all surgery. As you know, surgery is quite primitive and has been around for about 1,000 years. I think Sushruta from India described it many, many years ago. And over these 1,000 years, we have made some improvements, but it's still primitive compared to other sophistications like computers and software. So what's happening with prostate cancer and most cancers? In these days, we have come to use individualized or personalized medicine for most of these. And we use terms like risk stratification, tailored treatments, decision support systems, predictive models, MDTs, clinical choices in cancer. As patients and support people, you will all have come across these. And all these have made a big contribution to improvement in cancer care and prostate cancer care in particular. How do we have a more personalized approach now, and what's new? So I'll divide this into diagnosis, treatment, and follow-up. So in diagnosis, what's new? We have new now genomic tests, which will help us with risk stratification. And you might have heard in the literature or in the press or in the media about these tests. Oncotype DX is one, Prolaris is one, Decipher test is one. All these we read about a lot, but they're not available in New Zealand. They're available in the private sector in Australia to some extent, but they're widely available in the US. The downside with these is they've involved a lot of research and expenditure, so the tests cost a lot of money at this stage. All these tests cost somewhere between $3,400 to $4,000 US per test. So they're not here available in New Zealand at this stage. So Prolaris is one, Oncotype is one, Decipher is one, Confirmed DX is another one, ProMark. All these are being used in various stages in the prostate cancer management continuum in the US at the moment. So these are genomic tests which will help to tailor treatments for prostate cancer patients. For example, the Oncotype DX test will help to select patients who are candidates for active surveillance, which is not intervening but monitoring them carefully and only intervening if necessary. That, as you all know, allows the patient to have the best possible quality of life without allowing the cancer to get out of hand. The Oncotype DX adds to our current armamentarium in potentially choosing these patients and see who would be suitable for this. The Prolaris is another popular test, a test that's gaining popularity, and this will impact on the follow-up of patients at risk and see who would need a closer follow-up and who might benefit from actual surgical intervention or radical treatment. The Decipher test will detect candidates for early adjuvant treatment like radiation therapy in the high-risk group. So clinical criteria combining with these genomic tests will improve the personalization of treatment in prostate cancer patients. So that's a Prolaris report that's given to patients. And it's currently being used in quite a few places in the States. So here you can see, those are the clinical and pathological features. And then you get a Prolaris score, which is cell cycle progression of cancer. And you can see that that end of the spectrum is less aggressive. That end, as the score goes up, will be more aggressive. And then there's an average US distribution of the score within the American Urological Association risk group. And then you calculate the mortality risk with the Prolaris score combined with clinicopathological values. And then you decide on a threshold and see if they fall within that threshold for active surveillance or not. These are tools which will help you discern better who is a more suitable candidate and allows us to reassure patients that they're not being put in just the observation group without as much data as possible. Having said that, let me reassure you all that all the people that we have put on active surveillance currently and monitor carefully, we haven't, especially at North Shore, I can't comment about the data, but I know the trends, is that there aren't anyone who becomes metastatic because we put them on active surveillance. We really monitor them carefully. And even if we can postpone therapy for a few years, these people do really benefit from improvement in quality of life or maintenance of their high quality of life until we get to intervene. However well you intervene, you might have your operation done by the best surgeon in the world or the best radiation oncologist in the world. Your quality of life still won't be as good as it is before your treatment. So people forget that sometimes. And the anxiety with cancer diagnosis and the cancer drives people to make those decisions. This is how a Decipher test report looks like. I won't go into great detail about it because it's not available in New Zealand at the moment, and I don't see it being available for a few years because of funding constraints. So these are the common tissue markers for prostate cancer. So you have Prolaris, Oncotype, Decipher, Promark, Confirm, and each one is available ideally useful for watchful waiting or active surveillance, adjuvant radiation or salvage radiation, active surveillance, or whether to do a repeat biopsy or not. So Oncotype is the other test that's being increasingly used. And so what is this test? It's a tumor gene expression assay with a genomic prostate score or GPS. It helps guide initial treatments. And who is the test for? It's for mainly newly diagnosed men with low and intermediate prostate cancer, intermediate risk prostate cancer. And why do we do that? To improve risk stratification, pretty much. Again, the Prolaris test was developed and it was studied on biopsies of radical prostatectomy specimens. 31 cell cycle progression genes were studied, and there were 15 housekeeper genes, and they compared the two and they give a cell cycle progression score. The Decipher prostate cancer test is based on a validated RNA biomarker study. It was validated on 2,000 US patients. And this is also performed on a radical prostatectomy specimen. And then we use this to decide who will benefit from radiation as well as surgery. So personalized medicine, this is possible these days because of developments all around. Arnulf Stenzel, who is a well-known urological oncologist, cancer surgeon in Germany, says we are moving away from old diagnosis and therapies to those which specifically identifies high risk from low risk disease. Because we understand that we do tend to cause deterioration in quality of life, and there's a risk to patients in operating on everyone or treating everyone with radiation. So we want to pick out the people with the highest risk of deterioration or the disease affecting their quality of life and their longevity. We do not want to treat people who don't benefit from this, and we don't want to treat people in whom the effect of the treatment is worse than the effect of the disease. So that's where everything is heading. Freddie Hamdy, who's the professor of urology in Oxford now, says there are many agents that work after the cancer treatment, but we don't see the effect of that agent because the tumor volume is just too big. And the crucial task is to identify patients with high-risk disease and act within that limited window of opportunity we have. So if we can identify them at the earliest phase of the continuum and identify who's at high risk, then we can target treatment with minimal damage. So we now have predictive models which could be complementary to guidelines, and decision support systems are very useful. As Stephen mentioned, there's big data out there, and there's population studies, and we can use those data and use sophisticated computers to dig down and drill down into seeing which patient will benefit the most, which patient will not benefit and you will cause harm to if you grab them and treat them. So the future of precision cancer trials, therefore, will be hinged on all these issues. Genomics, targeted agents, functional and molecular imaging, which are new tests available, and they're just being introduced in the States, so they're a long way from prime time. Particle therapy and robotic surgery, and we've all talked about and read about robotic surgery ad nauseum. In the future, as the costs of robots come down and the expertise increases, I see it being available everywhere, especially when the single provider of robot currently loses its patents and other competitors come, costs will come down. You will be aware that a robot, to introduce it into a hospital in New Zealand, costs about 4 million New Zealand dollars. Not just that, it costs about $500,000 a year just to run it, to run the equipment, etc. I don't know how many of you are aware, but the company cleverly locks out instruments after 8 to 10 uses. So if we use a forceps 10 times, it doesn't open and close anymore. So we have to buy a new one. And Da Vinci, the company which supplies the robots, makes 83% of its profit from the instruments, not from the robot. So with time, we expect the competitors to come up. We were expecting them to come up this year or the next. But what Da Vinci has been doing is they're a business, so they are quite aggressive. They either sue their competitors quite aggressively or buy them out. So as soon as someone is looking like a threat, they have to disappear. And Da Vinci has been successful in doing that. But they can't keep on doing that for any length of time. And with our economy, we can't afford to put a robot in every public hospital or even the major public hospitals in this country. But that's something for the future. So the future of cancer research is integration and collaboration of all these fields, and it's becoming a hybrid discipline with oncology, computer science, bioinformatics, statistics, computational biology, and all those other things written there. So computers do help massively in decision support, and the amount of drilling down or filtering information that computers do is outstanding these days compared to what it was 20 years ago. And you have so much big data out there, and they promote a rapid learning approach by analyzing a large amount of data to support clinical decisions. And this is where predictive models and decision support systems help. They increase the general standard, and it's a great help to people like the general practitioners who don't work just with prostate cancer. They work with so many other conditions. So if we provide this to them, they can really use this to help us. Someone like me who deals with prostate cancer every day and is a relatively high volume surgeon for New Zealand, probably won't use that as much as the general practitioner. But it is definitely helpful. So what's the future with treatment? Precision surgery. And What I mean by this is, with genomic and genetic testing, like breast cancer, you can do genetic studies and see who is at risk of developing significant high-risk prostate cancer. And you can diagnose, you can pick them up early. They don't even need to have the diagnosis made. They can be offered prophylactic prostatectomies, like people like Angelina Jolie had prophylactic mastectomies. And that will come in the next few years. And then when that happens, those patients, they're not really patients because they don't have a disease just yet. But they will not accept any bad outcome. They want the best possible outcome, and they want precision surgery. And that is possible in the earliest phase of the continuum because you can then aggressively spare nerves. This is where high-volume surgeons and surgical centers will help because they will produce the best results, and they may be centralized. And I'm talking more about US and Europe at this stage. And by the time it comes to New Zealand, we all might be very old, but it will come one day. Robotics definitely helps. At this stage, it's more useful for the surgeons because it's a great tool to help operate with good magnification. But the skill and the quality of the surgeon is the most important factor. You can have a surgeon who does a bad robotic operation, and you can have a surgeon who does a very good open operation and produce a better result than a bad robotic surgeon. Remember, the robot does not do the operation, the surgeon does the operation. So these will self-select themselves in course of time, and the high-volume surgeons will produce better results. That's an acknowledged fact, and there's a number of studies that show that. But we are fortunate in New Zealand that our general standard is high, and our variance across the board is low compared to, say, the US or even Europe. There are some very, very good surgeons in the US and very, very average surgeons. But in New Zealand, fortunately for us, is quite uniform relatively. We may not have fantastic people like the best US surgeons, and that's only because they have numbers compared to us, but our general standard, average standard is very high. So I'll move on to surgery for oligometastatic prostate cancer. So have you heard of oligometastatic prostate cancer? That means someone with metastatic prostate cancer with small volume metastasis, not cancer everywhere. And there's been controversy about how to define this. Most papers have defined oligometastatic as 3 to 5 spots of cancer. There's one paper which suggested 10 spots, but across the specialties, we do accept that 3 or 5 metastatic deposits is oligometastatic prostate cancer. So is operating on it useful? It's not part of any guidelines or recommendations at the moment, but it's nearly there. And I'll show you why. We need to recall that prostate cancer, the untreated natural history of metastatic prostate cancer can be very long. People can live for 82 months, 100 months, up to 10 years with metastatic prostate cancer. If you look at the US figures, where there's 30,000 people diagnosed with prostate cancer every year, 3,000 people die, about 3 to 5% of initial diagnosis of prostate cancer is metastatic cancer. But 30% of people who die of prostate cancer every year are people with metastatic cancer who were first diagnosed as metastatic prostate cancer. So it's very important that we pay attention to this and see what we can do to reduce those numbers. I tried to get these numbers for New Zealand, but I wasn't successful. We'll keep trying through the cancer registry here. So you can see radical prostatectomy, PSA failure, metastasis, prostate cancer mortality. All this takes time, and there's a number of people alive. In the US, there are 3 million people currently who have been diagnosed with prostate cancer and are alive. So that's a big number. And as I was mentioning earlier, technology has evolved. Computers used to be in rooms that size, size of this hall. And more than that is being done by small smartphones these days. This happened in the last 20 to 30 years. So here is a study which was one of the first population studies to suggest local therapy might benefit in people with metastatic prostate cancer. You all might have heard of the SEER database. It's Surveillance, Epidemiology, and End Results database. It's a fantastic database in the US where we can, all these cancers are recorded and people can access this data and use it to see development of disease patterns and then extrapolate with these Kaplan-Meier curves and see where we are heading. So low-risk patients seem to benefit more from local therapy. As you can see, local treatment is that brown graph, and no local treatment is the blue graph. And this is 15,000 patients with M1 disease. That's usually, not by definition oligometastatic disease, but likely to be oligometastatic disease. So it also, because of the sheer numbers, 4,000 patients there, you can adjust for confounding results and see what the pattern is with all these patients who are getting treatment. See here, RP is radical prostatectomy, which is the brown one. IMRT is radiation therapy, intensity modulated radiation therapy, which is the green one. So you can see that they're similar, and as time goes by, radiation does produce slightly better results than radical prostatectomy in that scenario. So with bone metastasis, again, you can see the same thing. Small numbers, but you can see how they separate off. Yet another population study. Again, you can see if you just put people on hormone therapy alone, they do the worst compared to people with prostatectomy and androgen hormone therapy or radiation and hormone therapy. So multimodality treatment is the other new thing that's being discussed worldwide among all the specialist groups, including surgeons and radiation oncologists. We acknowledge that there are some cancers in prostate which are high-risk cancers where adding surgery to radiation or radiation to surgery, as well as hormone therapy, as well as chemotherapy, is producing better and better results. And this is where MDTs are very useful. If you discuss them across the board with all the specialties and each one contributes to his or her expertise, then we get the best decision for the patient. For example, on next Wednesday, I'm operating on a 53-year-old man who presented with a PSA of 53 and had metastatic prostate cancer. We discussed it in our MDT, and we decided that he should get docetaxel chemotherapy. He did get that for 3 months, and he's recovered now. His PSA has dropped to 3, and scanning showed no metastatic disease. So we went back to the MDT again and discussed it, and we agreed that surgery at this stage would be good for him. So I'm going to give him the operation on Wednesday, and he is keen to go ahead with that. The alternative to that is to allow the disease to get you. And these decisions, again, have to be really well thought out, well discussed, and we should do the right thing by the patient. You can also use PET scans to direct salvage radical salvage lymphadenectomy. And this is being tried in some centers in the US. Small numbers, 52. We haven't done that in New Zealand. But again, these things can be ready for prime time in the future. So, to conclude, oligometastatic prostate cancer probably has a better prognosis than polymetastatic prostate cancer. That's intuitive, Even a non-medical person should be able to, it makes sense logically. And treatment of prostate may provide some benefit in oligometastatic disease. If you look at the results of chemotherapy in general and the basis on which chemotherapeutic agents and immunotherapeutic agents are being funded, they usually provide 2 or 3 months survival. and so they go through FDA approval for that, and they get funded. They're hugely expensive, a massive burden on the health budget. But for the individual, that's important. So compared to that, surgery, although it's 1,000 years old, if we can reduce a lot of the bulk with the operation. But an operation sets people back. So in terms of recovery and time spent in hospital, etc., etc. So that has to be taken into perspective. So if we combine surgery and reduce the bulk, cytoreduce, and then hit the cancer hard with radiation and hormone therapy or chemotherapy, a patient with particularly high risk prostate cancer might get the best benefit. And there are some papers and a lot of research being shown that it is true and beneficial. Treatment of metastatic disease may also provide some benefit. Treating the mets themselves. Lymph node dissection or radiation for nodal mets, external beam radiation therapy for bone mets. None of these should be made ad hoc by just one urologist or one specialist sitting. It would be best if it's discussed in a multidisciplinary team meeting where input is obtained from everyone concerned, and we do the best for the patients. We should not treat patients inappropriately and give them more side effects and do more harm than good. So the MDT process has evolved quite a bit, and in all the major centers we have a robust MDT process these days.